Good evening. It's 8 o'clock and welcome to today's episode of Marvelous Medicine. Today's topic is Aorta, the silent killer. The speaker is Dr. Bashi. He's the chairman, Aortic Aneurysm Center, Director, Institute for Cardiac and Aortic Disorders, Senior Consultant Cardiothoracic and Vascular Surgeon at SRM Institute for Medical Sciences Hospital, Chennai. He's also an adjunct professor at the MGR Medical University, Chennai. Dr. Bashi did his MBBS and then MS General Surgery from Trivandrum Medical College and MCH Cardiothoracic Surgery from Christian Medical College, Vellore. He is a pioneer in beating heart bypass surgery and arterial grafting for bypass surgery in India. Dr. Bashi specializes in complex re-operations for aortic aneurysms, coronary bypass, and valve surgeries, and has described 2 new surgical techniques in the field of aortic surgery. He has published more than 150 articles in national and international journals and given several guest lectures, orations, taken part in live surgical workshops, and participated in CME programs all over the country and the globe. He has received several awards, the latest of which is the Lifetime Achievement Award from the Society of Minimally Invasive Cardiovascular and Thoracic Surgeons of India in 2022. Thank you, Dr. Bashi, for readily accepting our invitation to participate in the Marvelous Medicine series. Moderating the session will be Dr. Shekhar. He is the head of vascular and endovascular surgery at Kaveri Hospitals, Chennai, which is recognized by the National Board for both vascular and endovascular training. Dr. Shekhar did his MBBS from JIPMER Pondicherry, MS General Surgery from PGI Chandigarh, and MCH Vascular Surgery from Madras Medical College. Quest for learning led him to do endovascular fellowship at Royal Perth Hospital in Australia. He has the largest series of vascular reconstructions in diabetics, Buerger's disease, and aorta arteritis in India. Dr. Shekhar has published 40 papers in national and international journals and has contributed chapters in major vascular surgery books. He has strived hard to popularize vascular surgery among students, medical fraternity, and the general public. Dr. Shekhar received the National Award of Excellence for Outstanding Work in Vascular Surgery by the Orthopedic Association of India and the Best Doctor Award by the Dr. MGR Medical University. Thank you, Dr. Shekhar, for agreeing to moderate this session. Over to you, Dr. Bashi.
Thank you, Vidya, for the generous introduction. Thank you, Shekhar and Patta, for organizing this program. I'm very thankful for all of you to inviting me for this evening program. It is a very good initiative, learning general surgery. I'm sure there will be a lot of people attending this. I would start with the famous saying of Swami Vivekananda on imparting knowledge is like a river flowing into an ocean. The more it flows, the more it fills. So we all have to impart our knowledge so that the river keep flowing. So as you keep imparting, fresh water will come into the river, because the river, if it doesn't flow, the water gets stagnated. Aortic, can I share my screen?
Yes, sir.
Yeah. So I chose this topic of aorta because very people among even among the medical profession as well as among the public, there's not much awareness of aortic diseases, because a lot of the disease of the aorta goes silent, especially the aneurysms, and dissections catch you with the surprise, and most of the time it may be misdiagnosed in many parts of the world itself. I mean, even earlier, a lot of aortic diseases used to be missed. I remember, olden days, we never used to see many of these aortic diseases coming to the hospital, or people sometimes sudden death occurs and they think due to myocardial infarction, cerebral hemorrhage, and other common causes. So aortic dissection especially is a silent killer. So unless people are aware of this disease and its clinical presentation and diagnostic modalities, a lot of patients are being treated with for myocardial infarction, because sometimes the symptoms may be similar. Patients presenting with the same clinical symptoms. So I chose this mainly. I will be speaking because the topic is so far vast. I will limit into a general principles, the etiological factors, diagnostic measures, the teamwork, and what is to be done in an emergency. So I won't go into the details of everything. So to come to the basics of aortic anatomy, as we all know, aorta has got, it starts from the aortic root, aortic valve, coronary arteries, then the aortic arch vessels, and comes down and divides into the different branches. So it supplies all these vital organs are preserved by the aorta. So any problem happening in the aorta first will affect the heart if the coronaries are involved, and then it can affect the brain. Aneurysm can occur in the descending aorta, thoracoabdominal aorta, producing malperfusion or rupture causing sudden death. Now, just to see, this is the normal diameter of the aorta. Usually, it varies from 2 to 3.5 centimeters at different levels. So, to diagnose and also anatomy of the aorta, as we know, it is the intima, media, and the adventitia. And aneurysm for the diagnosis of an aneurysm, the diameter of the aorta has to be about 50% more than that. Is 1.5 times of the normal in a focal region. You say it as aneurysm. It is derived from the term aneurysma. So this is a distal aortic aneurysm in the thoracic aorta. It can have in the lower thoracic aorta and thoracoabdominal aorta. And because of the pulsatile nature of the flow, it keeps on increasing. And in dissection, what happens is the aorta, the intima of the layer and the media breaks, and you can see the blood leaking into the layers. And depending upon the site of tear, commonest 70% of the tear occurs in the ascending aorta and 30% occurs in the descending aorta, maybe a small percentage in the aortic arch. So if it occurs in the ascending aorta, it's a very serious problem. Descending aorta is less serious. Ascending aorta, that we call a type A aortic dissection, which will come to the classification later. So if left untreated, ascending the type A aortic aneurysm, 33% of the patients die within first 24 hours, or is almost 1.5% of the patients die in the first. That's the importance of diagnosis and treatment immediately. 50% die within 48 hours, and 75% of the patients are dead in the first 2 weeks in a type A aortic dissection. So that is the depth of the problem. So what are the risk factors of acute aortic dissection? Now, one of the things is bicuspid aortic valve. About 10% of the normal population will have bicuspid aortic valve. And old age, atherosclerotic diseases, the connective tissue disorders. That is one of the other things which presents in younger patients, like Marfan syndrome and other connective tissue disorders. The aorta enlarges and dissects in early age. Then another study recently has shown that a person who has got an aortic aneurysm in his family has got about 10 to 15% chance of getting an aortic aneurysm. Then aorta arthritis, which is an inflammatory pathology, drug addicts, hypertension uncontrolled is one of the main causes. Pregnancy, aortic dissections occurring in pregnancy, usually it is associated with connective tissue disorders. Then another entity now is after cardiac surgery, like after bypass surgery, after aortic valve replacement sometimes, and also aortic annulation sometimes itself can produce dissection. So what are the life-threatening complications? So depends upon the involvement of the ascending aorta. So when the ascending aorta is dissected in the aortic root itself, the aortic valve becomes incompetent. It just dilates and patient may develop acute aortic incompetence. Patient will be very sick, breathless, and may require emergency attention. Then it dissects the coronary arteries, so it can get mechanically obstructed. Patient can present acute myocardial infarction, or if the artery ruptures, patient can have sudden death. Rupture is another fatal complication. Sudden rupture, these are and tamponade, blood leaking into the pericardium. Then the dreaded complication is the visceral malperfusion, resulting in ischemia of the viscera and the kidney, and patient can present with cerebrovascular accident, sometimes comatose or stroke, depending upon the involvement of the area of the aorta. That is the reason I say that it is an emergency. These are the reasons by which patient die in the first 72 hours or in the first 2 weeks. So the most important thing is to get the patient. First, you have to diagnose and get the patient to a center where it can be done. So as I said, in younger patients, Marfan syndrome is one of the commonest reasons for dissection, and smoking. So now we see a lot of aneurysms increase in numbers, because when I used to work abroad, we used to see a lot of aortic aneurysm. Then I thought, why in India it is less? Because those days, those countries, the average longevity has gone up almost to about, in Europe and USA, it's almost about 81. And now in India also, the average longevity is almost about 71 years. So as the aging population is increasing, there is a large number of patients we have to cater to, who comes with mainly atherosclerotic aneurysms and also dissections. So as Shekhar will know, that a lot of abdominal aortic aneurysm is very common. Thoracoabdominal also is common in older people. Now, clinical features that I said earlier, it may present like a myocardial infarction, severe pain. And some patients say, I have a lightning pain migrating to the neck. So it is important to analyze the clinical diagnosis. The clinical, a lot of times, if you talk to the patient, you may get some clue about the diagnosis, because I have had cases, at least a few cases, where patients were diagnosed acute myocardial infarction and thrombolized. Afterwards, somebody does an echo and find out there is a tear in the ascending aorta and aortic incompetence. So a high index of suspicion is necessary to diagnose this problem. So sometimes, even there were instances of a patient, while waiting for investigations, patients have died in the casualty, in my experience. Well, so shifting from the emergency room, on the way, patients have died. After reaching to the ICU, shifting to there are so many times, patients, sometimes you lose the patient. And when the patient suddenly arrests, they just exsanguinate. Even inside the hospital, you won't be able to resuscitate this patient. So that is the importance of diagnosing this. So sometimes the patient may present with a stroke, paraplegia, anuria, ischemic leg. They may be the only presentation, because I have a couple of instances where patients have undergone embolectomy for ischemic leg, thinking that an embolus, or patients are dialyzed because of renal failure, where the renal compromise with aortic dissection, and then patient comes with gangrene of the bowel. So once the patient comes with signs of gangrene bowel, you do a ultrasound or a CT, you will diagnose. Today, because of CT, plain CT available in almost every place in nook and corner of our country, more cases are being diagnosed. It is a simple investigation. So there are some centers where there is a standing instruction. Any patient suspected of, if you have any doubt about the diagnosis, acute chest pain, sweating, where you don't think it is a myocardial infarction, straight away send the patient for a CT. And if CT shows dissection, you can do a specific test, CT aortogram, which will tell us the exact diagnosis. Now, this is the old classification of DeBakey, where ascending aorta is involved. You can type 1 and when descending thoracic and type 3 and type 2B. And the Stanford classification is simpler, where Stanford A is ascending aorta, B is descending aorta. Another classification based on the duration of the presentation of the patient. So when patient presents within 14 days, it is acute aortic, as you can see the angry looking aorta with the hematoma all over the layers. This is a chronic dissection where the aortic root is dilated. It's a localized dissection. Subacute when the patient presents within 90 days. Chest X-ray, of course, is not a very important investigation nowadays. Hardly anybody does X-ray in the emergency. Most of the times, these are old, investigations only. But if you are sometimes in a local place where you have nothing else, an X-ray sometimes find some widening the mediastinum, which make you suspicious. Sometimes if the aorta ruptures, it can present with a pleural effusion also. Another important investigation is an echocardiogram. You can see here, you can see the dissecting flap moving in and out. It's a classical appearance of aortic dissection, the echocardiographic appearance in it. And this is more more can be documented with a trans-esophageal echo. This is a real regular aneurysm. This is a dissection. But one of the problem we find was you should be having a person who is good in doing an echo in an emergency room. Otherwise, you may miss. Sometimes, if you are good in clinical examination, you pick up aortic incompetence. That will give a few patients coming with acute chest pain presenting. And the most important investigation today is the CT aortogram. CT aortogram and CT scan, you can see the different pictures of this is a patient with a distal aortic aneurysm. This is a thoracoabdominal extensive aneurysm. This is a young boy whom I did a thoracoabdominal replacement. 22-year-old boy presenting with a genetic problem, that is connective tissue disorder. This is the classical appearance of a type A dissection, just showing a few examples of aneurysm and dissection. And you see how it has happened. See now, this is a dissected flap in the arch. So you have to have a combination of all these axial and sagittal and coronary images. You should have a good diagnostic radiologist, very important. Because as surgeons and physicians, we are not expert in interpreting this. But over the years, we all have to learn how to interpret. So in an emergency, you may not get sufficient help. Looking at the CT itself, you may have to diagnose and plan the treatment. It is very important. One important point I want to highlight is in aortic dissection is to decide what is to be done. Because when you open up an aorta where you can't find the dissection flap and site of entry, you are clueless as to what to do. So proper preparation, especially in any aortic surgery, other than an emergency, I always say the operation doesn't start in the morning of the day. It starts on the day before. There's a famous saying by Abraham Lincoln that if I am given 6 hours to cut a tree, 4 hours I will do for sharpening my axe. So the sharpening the axe is very important, which is applicable in aortic surgery, because you have to really prepare properly and get at a diagnosis. And this is just a transesophageal echo. So the goal of aortic surgery in aortic dissection is replace the diseased aorta, whether it is aneurysm, you put an interposition graft, and during the operation, especially in the aortic arch and descending aorta, you have to protect the heart, protect the brain, spinal cord, and viscera. Sometimes you may have to do associated procedures like bypass surgery and valve replacement. So this is what I was trying to say, to have a team. A good aortic team is necessary for success, because all these are complex procedures. So today, with the availability of good CT scan and good intervention, diagnostic radiologists, as laser precision, you can find out where is the problem and treat the patient accordingly. So the team usually should consist of a cardiac surgeon with the lead, with the diagnostic radiologist, very important, and an interventional radiologist, and a clinical cardiologist, and a good anesthesiology team, and most important is a good perfusion team, because myocardial, the cerebral protection, organ protection, hypothermia, all these are very important to get a good success. So in an emergency, as I said, the high index of suspicion is very important as to find out the diagnosis. And once you diagnose, most important thing is control of blood pressure. Usually that is being neglected. When emergency patient comes, everybody will running around, getting X-ray, CT scan and all those. But it's very important that one person should take attention to control. Most of the time I have had occasions, patients coming with 200, 240 blood pressure and all. Because a lot of patients with hypertension, they ignore. One of the things I find in our population is, when somebody takes a blood pressure medicine, it becomes normal. Then they will check with one of the neighbors and say, sir, if the pressure is okay, you don't have to take medicine again. So they treat themselves. They think when blood pressure is normal, and if you take blood pressure medicine lifelong, it is a sin. So I see a lot of cases of people just ignoring. Majority of the patients coming with the dissection will have uncontrolled blood pressure. So that is a vital thing in management. In fact, olden days, that was the only treatment. Wheat regime, we used to call as house surgeons, we were only asked to control blood pressure and aortic diseases. Then proper anxiolytics and analgesics, because they will have sometimes tearing pain. So this investigation, which I always said, for example, in our hospital, if a patient with aortic type of dissection comes, within an hour or two, we will be able to take the patient to the operating theater. Another thing also you need is a good blood bank support, because most of these are long operations, and patients may have coagulation abnormalities. Some of them may already be thrombolyzed, or patients may be on aspirin, clopidogrel. So all these are problems which occur in the middle of the night. Unfortunately, these cases come in the middle of the night where we are least prepared. And availability of the graft, availability of blood products, all these are important. This is what is aortic aneurysm. So this is just a diagrammatic representation. We put a graft. This is a graft we stitch on either side, so blood flows through that. This is an endograft where without surgery, we introduce the graft percutaneously through the femoral artery. So as I said, there will be an entry tear that has to be eliminated. Then entry false lumen will be there proximally and distally. Both has to be obliterated. So that is, we put a ascending aortic graft. Sometimes, just a graft alone is enough. You obliterate the false lumen there and here, and if the valve is normal, that may be a simpler procedure. But if the valve is leaking or calcified, you may have to replace the aortic root itself. That means replacement of the aortic valve and reimplantation of the coronary arteries, because that becomes a very complex procedure. Now, proximal limit, as I said, interposition graft, Benthal's operation. Sometimes valve preservation, that's a complex procedure. It's all different methods of preserving the aortic valve. Distally, as I said, even a type A dissection, sometimes it can occur in the aortic arch. In that case, we may have to do a proximal arch replacement, because if you leave a residual tear inside, it can produce problems postoperatively. And if it involves distal arch, you have to do a total arch replacement. All these are complex procedures, and the latest is complete repair using a frozen elephant trunk, which we do in selected cases. These are all can be done only in highly specialized centers. You need a lot of expertise and experience to get good results. But a basic thing I would suggest is for a person who is just dealing with aortic dissection, first just a replacement of the ascending aorta, and maximum aortic root if necessary is the safest thing. Because even if you leave some residual disease, the patient may come out of the theater alive. Later on, we can tackle. Always, it is better to have a live dog than a dead lion. You try to do a heroic surgery, in the end, the patient will die of bleeding and other complications. So, if you are not very experienced in doing complex procedure, just a simple thing is to excise the tear and just put an interposition graft. So now the protection of the treatment. This is a Benthal's procedure. What we do. Just want to show a diagrammatic representation. In Benthal's procedure, this is a graft and a valve, and then reimplant the coronaries inside. This is a complex thing, whereas straight aortic ascending replacement is much simpler. Now, this patient actually came to our emergency room about 4 years ago. This is a lady, because she survived only because she was living in Vadapalani. This is how a patient dies. You see how blood is leaking through. The moment we open the chest only after everything is cannulated. Otherwise, he will just exsanguinate and die. My finger is on the hole in the ascending aorta, which I will show you. The moment we cut the pericardium, blood pressure from 70 shot up to 150. My finger, we are on cardiopulmonary bypass now. And I'm keeping the finger. Now you can see the heart is arrested. Femoral cannulation. When you open, you can see the dissection. See how there is like a banana peel it is. Just the layers have separated completely. And the aorta is transected, you can see. That is a classical type of dissection. So friable tissues. Now you can see my forceps is going through a small hole in the adventitia through which it was leaking. So this is just an example to show how a patient can die. She went home on the 7th day, she's still alive. So she was brought on a Sunday afternoon with the hypotension. That was the presentation. Suddenly in shock, immediate, that is the end result. We have replaced their aortic root and ascending aorta. Now just supporting on bypass to come. So how you can save a patient if they come on time. And importance is to get the patient to the operating theater. This is just to check the aortic valve, whether to replace it or not. Yeah. And this is also to how to prepare the aorta. You can see the proximal aorta is all dissected. So we are like a sandwich, make Teflon felt inside and outside the aorta so that you will have some meat in taking the stitches. The tissues are very friable. So the stitches have to be taken very, very carefully. So this is under circulatory arrest only we are doing. The aortic arch is open. We are doing the distal aortic anastomosis with antegrade perfusion. You can see the cannula going into the carotid here. Patient's temperature we cool to about 24 degrees centigrade with the open arch anastomosis. This is also how we will prepare the dissected aorta. Put different pieces of Teflon inside and then suture it together. Because the most important problem in these cases is bleeding. Every suture line will bleed once you come off bypass because you have to heparinize the patient. Sometimes you have to take a long time to get everything done. Now you are checking the aortic valve, putting some water. It's a competent. So it's a simple case of ascending aortic replacement. So this is how it looks. You can see on the right hand side, you have replaced the aortic root in this patient. It's an aneurysm. This is also another case, huge aneurysm. Actually, this patient was a doctor, a localized dissection there. We did a root replacement. It's called a Bentall's procedure. It's also another example. Now, David's procedure, I said, is based where you conserve the aortic valve. When the aortic valve is normal, we can just conserve the valve so that artificial valve can be avoided. Now, the next treatment in aortic aneurysm is endovascular stenting. This is an infrarenal aneurysm where you put a stent graft. This is done percutaneously, where the aneurysm is excluded with a stent graft. This can be quite simple to the patient, but it's expensive. The endograft may cost sometimes like 8 or 9 lakhs of rupees because 2-3 pieces extension and all those things. But usually it is done in older patients who are not fit for laparotomy. Olden days we used to do a laparotomy and do a end-to-end anastomosis here. Now most of the cases are done by endografting. EVAR it is called, endovascular grafting of the infrarenal aorta. Thoracic aorta also it can be done. It's just a EVAR for dissection. So when type B dissection, that is we were talking all this time about type A dissection. Now type B dissection is when there is a dissection of the thoracic aorta distal to the subclavian artery. So the aorta dissects down, usually the entry point will be somewhere here only. I'll show you you can see the entry point. So this graft actually covers the entry point there. And when you release that, it's all this expands. There are small hooks there which hold the graft there. Only problem is, it has to be distal to the subclavian artery. When subclavian artery and arch vessels are involved, you cannot do that. Now distally you put a non-covered stent so that the false lumen and true lumen are approximated. So that is a classical treatment for type B dissection when it is complicated. Complicated type B dissection means whether there is leaking, persistent high blood pressure, or increase in the diameter of the aneurysm or size of the aneurysm in the presentation itself more than 5 centimeters, or visceral malperfusion. So that is called complicated type B dissection. Uncomplicated type B dissection, usually medical management is first, and then only we do the thing. This is also another, this is an aneurysm actually, thoracic aneurysm. We have done an endograph, huge extensive aneurysm of the thoracic aorta. Now, the challenges we face in India, actually, to get a patient, I have had many instances, patients coming from by ambulance from Trichy, patients used to come from Vijayawada, Hyderabad, different places where the expert thing is not available. Patients usually come in ambulance. Some occasions where the people have died on the way also. Then the availability of the expertise not available in the most many cardiac centers, they are not equipped to do this. Then another factor also is a cost factor, because somebody develops a type A dissection, come to the emergency, they cannot produce about 5-6 lakhs or 7 lakhs of rupees suddenly. But unfortunately, to do this operation, the consumables itself will come to more than that. So most of the private hospitals, it's difficult to accept a patient for surgery unless the money is mobilized. At least some amount of money you have to pay. That is another problem. Then the lack of awareness among the people also, because sometimes they don't go to the hospital. Aneurysm dissection or something happens. It's an uncomplicated one. They may refuse to go to the hospital and wait and come in end stage only. Then availability of the grafts. Also, all the available things may not be there. Sometimes we have to innovate and make our own ways to get. These are all endographs or grafts made, handmade here also to save cost. See that you can see this is a ready-made graft, which is very expensive. It may cost about 1.5 lakhs. Whereas if we stitch all this, we may be able to make it about half the price. So the problem is sometimes this can leak. All these are practical problems. So this is a ready-made graft for thoracoabdominal aneurysm, but here we make by hand. Like valve conduit, this is ready-made. It is very expensive. This we make with the graft and valve. So a lot of things we have to innovate ourselves to do the procedure here. Otherwise, we won't be able to do that. So another problem which we find is malperfusion. That is, as I said in the beginning, malperfusion can occur starting from the coronaries to the brain, to the viscera, to the peripheral arteries. This is an example of a patient. This is how he came. Absence of pulse. That was the presentation of the patient. You can see it is cut off completely. And after the operation, the most common malperfusion is the peripheral. And then you can see coronary malperfusion. Mesenteric malperfusion, fortunately, is the least, and cerebral malperfusion. And this patient completely recovered. About 10 to 15% developed coronary malperfusion. You can see the coronary is dissected, and sometimes a patient may not reach the hospital if it is a massive. Cerebral malperfusion occurs in about 6 to 14%. It could be partial or complete occlusion. Patient may present with hypoxic encephalopathy or embolism or thrombus in the false lumen. Mesenteric malperfusion, I said, it is a very difficult problem. Patient develop gangrene of the bowel. This is only one condition where you treat the malperfusion first. Whereas in all other malperfusion of the aorta, aorta, what we do now, viscera, usually what we do the aortic, correct the central correction you do first. So that, cerebral malperfusion improved, coronary malperfusion definitely will improve, visceral the renal malperfusion, all of this improve. Whereas visceral malperfusion, patient will be in shock, acidosis, because of the ischemia of the bowel. They will be very, very sick. So sometimes the mortality is almost 50% in a visceral malperfusion. This just see how important is this patient, the previous same CT only. See the post-op CT. Once you do the root replacement, everything has correct, and it is, the lower limb is fully perfused. When the patient came like this patient actually had somebody tried to do a femoral embolectomy in a peripheral center. because patient presented with the absence of pulse. Luckily, his aorta didn't rupture, so he reached us and we did a root replacement, and that is this thing. This also one patient presented with paraplegia, a young fellow. On a Sunday afternoon he came. He was sleeping. Actually, he was supposed to go to the US next day, and then the whole aorta got occluded at the thoracic level, and we did an arch replacement, just a picture to see total arch, and then axillofemoral bypass. You can see totally perfused. He walked home, recovered from paraplegia. So renal malperfusion, I had, this is a patient who was being dialyzed in a very big hospital in another state. And he was having dialysis for 2 weeks and no improvement. Then they came to us and we did an arch replacement and stent graft. And within 2 weeks, his renal functions became normal and went home fine. So I've already mentioned about the challenges for expertise. Ambulance service is another, because our transport is a big problem, like air ambulance services has not picked up. Most of the patients have to travel by road. So the incidents in India, the reported incidents, actually we don't have any real incident, but almost 600,000 patients are in need for aortic surgery in India per year. Put all this, but in reality, see, just to have an idea of how many centers are doing, about 400 to 500 cases of type aortic dissection is only treated in India. This is by source from phone calls and industrial data, and we find more aortic dissection in winter rather than in summertime. Majority of the patients in our group were 40 to 50 years. So is the incidence really low in India? I don't know. Or do the patients die before they reach hospital? We are also trying to do some estimates, and to, unfortunately, no real data is available regarding the size of the aorta, because we all go by the data from the Western countries. The size of the aorta is definitely smaller than Western people. So when you say about the indication for surgery, when you say like more than 5 centimeters in Western population, we don't know whether we should reduce that into a lower level in our population. It's a questionable thing. We are also going to doing some studies to find out what is the size of normal aorta, so that we can have some guidelines. I'm sure all those things are going to happen. And I always tell the younger surgeons, there's a lot of scope for everybody is very reluctant to get into this area, because it's a very tiring and long procedure. You have to, and also end of the day, sometimes the patient may bleed. Again, you'll have to go in the night. So I always say the energy I take to do a aortic dissection, I can do about 10 coronary bypass surgery. So I tell everybody, the future is so good. So many patients will be getting, so many cases will be diagnosed, and we can save so many patients if you have the ability to tackle them properly and send them home. So now to conclude, dissection is of course a life-threatening problem. Early intervention is mandatory. Surgery in experienced hands has excellent results. There was a study from the United States about 5 years ago to show that experience and the result. A center which does less than 5 patients a year of aortic dissection, the mortality was as high as 20 to 25%. Whereas center which does more than 25 cases a year, the mortality was around 5 to 7%. So that just to show how much experience is necessary to tackle this. Of course, in aneurysms, aortic aneurysms, as I said, without dissection, early detection is important to prevent rupture. And see, like a simple X-ray chest in patients who are at risk, like people who are over 65, who have hypertension, who are smokers, diabetics. An X-ray sometimes will find out a dilatation of the aorta, or just an ultrasound of the abdomen may give a clue of an early aneurysm which we can follow up. Now, endovascular procedures have gone in a very big way in treating all these patients who are otherwise unfit for patients, because a latest hardwares are available. The technology is developing very fast. 20 years ago, we could never imagine the type of the software available, hardware available today. Even thoracoabdominal aneurysms are being tackled without surgery. And hybrid operations are performed in extensive aneurysms. And most of these patients with connective tissue disorders need lifelong surveillance, because when the patient has got a dissection, sometimes the distal aorta can enlarge. They have to be on proper surveillance and proper blood pressure control, and patients to avoid smoking. All these are important. Sometimes in familial cases, we have to screen the family members and make sure they are okay, because I have 2-3 instances where about 3 people of Marfan syndrome I have treated, mother, son, and daughter in 3 families. 3 of them had Marfan syndrome and then required aortic root surgery. And now aortic valve conservative procedure. Olden days we used to replace aortic valve. All these cases now we repair the valve. Lot of development has occurred in all those things, and the future is quite bright going to be. Yeah. Thank you for your kind attention. And once again, I thank Vidya and Patta for this, inviting me and continuing this program. I'm very much obliged to you for inviting me. Thank you for patient listening.
Over to you, Dr. Shekhar. Thank you, Dr. Bashi. Dr. Shekhar, you're muted. Dr. Shekhar, you're muted.
Yeah, thank you, Bashi, for a nice presentation. You made it very simple so that people can understand. There are a few questions. You know that definitely aneurysm incidence in India is less. Have you found any reason particularly for that? As compared to UK, no, UK is really high. But you said one thing, our longevity is going up. But apart from that, is there any other reason?
No, I'm not. Maybe, see, I also have this same doubt only, because when you go see the series from China and all those places, no, they have, and Japan, so much of aneurysm cases. So one of the reasons I find, because their longevity is very high. As you live longer, the atherosclerotic aneurysms will be high. Secondly, we may have some genetic factors where our diet, or whether we are not diagnosing. If you look at the 1.3 billion people, how many are coming to the hospital for diagnosis of this problem is a question. That is the thing. Unless we don't have any statistics to authoritatively say the incidence is less, but we don't see many, that's a fact. Everybody says like that. When you go to other parts of the world and listen to meetings, like I went to a small town in Germany about 15 years ago. It's Munster. The population is only 2 million. They are doing 1,200 aneurysm cases, vascular cases in one center there. I was amazed. A 2 million population, it's quite a lot. So I can't really give a correct answer for that, because unfortunately we don't have any sort of statistics to prove that. Obviously, your observation and other people to say it is definitely less only. I agree with you.
And the other thing is, we seem to be seeing the more dissection than aneurysm.
Yeah.
Of course, with the advent of CT angiograms, I think they are being picked up more often.
Yes.
Which is very true. And you left out vascular surgeons from this group. This is one of the overlap areas.
Yeah, I know. I was asked to, the aorta means central aorta only. That's why intervention. You are there. That is why I didn't have to talk much, because the time I didn't want to go to overtime. That is one of the reasons, because you are there to supplement everything. Yeah.
Shiv has his hand up. Yes, Shiv, go ahead and unmute yourself. Yeah.
About the I think incidence of aortic surgeries or diagnosing aortic aneurysms, why it is high in UK, it's probably the healthcare system. It's got nothing to do with the diet or to do with detection and things like. It is just that the system you have in UK, where the patient is seen by GP regularly, they're investigated. The pickup is actually much more. Uh, Unlike in India, where people only go and see the doctor when they need to, actually they got some problem, they go and see it. So that's why it is not diagnosed. Like I had one of my today's patient. One of the things was my junior said, "Sir, he's got a aneurysm." I said, "That's fine. It's only 4.5 centimeters." So he's under surveillance. So patient is actually having a total knee replacement, but we know that this patient has got an aneurysm. So he'll be under surveillance,
No,
and that's the only reason.
can I interrupt that? See, the answer is yes and no. I agree that we don't have a kind of a surveillance that is done in the United Kingdom, but you see, ultrasound is available everywhere now in India, and people are getting ultrasound done for so many things. You talk to any of the ultrasound labs, they don't see that many aneurysms like what has been reported there. In fact, the ultrasound surveillance for anybody over 60, smokers, the kind of this thing that was done in United Kingdom has not been done elsewhere in the rest of the world, because the pickup rate was not as good as what was in UK. UK is a special case. UK seems to have the most number of aneurysm as compared to even the rest of the Western countries.
It's not about whether you getting ultrasound done or not. So unless there is awareness that we need to look for it, you can miss it out easily. Aneurysm is not unless you measure the size of look at it. And now here, particularly, for example, one of my ultrasound machine has been donated by the vascular group. These are specialist nurses who are actually doing the scanning, specifically for the aneurysms. So unless you look for it, so there may be, we got ultrasound machines everywhere. People are getting ultrasound done for a lot of things, but unless you specifically look for it, you're not going to find it.
Point taken. There are some questions in the chat box. Would you like to address that, Dr. Bashi?
Yeah, sure.
Yeah. So, sir, from your experience, any tips in the technique of suturing of the dissected ball? Time of surgery after dissection without malperfusion. Timing, I suppose he means how soon you should do it.
No, timing, type dissection, there is no question of waiting. The earlier you can do the patient, the better will be the result. Because as you know, they can die due to so many other problems related to the complications which can occur in type A dissection, especially aortic incompetence or malperfusion syndrome. That is the answer for that. You shouldn't, because there are some centers, I know some patients say, so you wait for 1 week, the patient survive, you do the operation. So that should not be the attitude. Type A dissection should be taken to the operation theater and operated as early as possible. His expertise is available if you are confident of doing the operation. Now, number two is suturing techniques I have shown in the video. Important thing is to prepare the proximal and distal aorta with Teflon felt inside and outside. Sometimes we use some glue just to reinforce the sutures. Carefully, very, very carefully, you have to take every suture has to be very carefully, close sutures is very, very important. Liberal use of proline, and never hurry through to prepare to suture an ascending aortic graft. You take your own time. 10 minutes you take extra will be worth about 2 hours after surgery, because sometimes just a suture line bleeding itself can kill a patient. So proper preparation of the cuff, that is proximal cuff, if you are replacing the ascending aorta. Distal, of course, always you should do on an open aorta. Without clamping the aorta is better, because in a clamped aorta, suturing is difficult. So you have to have a temporary circulatory arrest with the hypothermia. So if you do that, normally the bleeding will be less. Still, patients can bleed, but care to the maximum preparation is necessary since the tissues are very friable.
Now, only type B dissection that you will have to wait.
Yes.
The initial treatment is medical. Allow the BP to be brought down, give good analgesia, and then the whole thing is going to be inflamed. So it's better to avoid an acute surgery And type B dissection without malperfusion gives you that time to prepare. And majority of these patients are now managed with TVAR. So TVAR, sometimes you have to cover the left subclavian, in which event you need a carotid subclavian bypass for that. Otherwise, type B dissection, now the standard treatment is putting a TVAR.
Dr. Achal has asked this question. What's your brain protection strategy for arch replacement?
Brain protection, first of all, we cannulate the axillary artery or the carotid artery. So systemic perfusion is started to that. Then we cool the patient to about 24 degrees. 24 degrees we cool. Then we arrest the circulation, and usually I give antegrade perfusion to the left carotid also. So bilateral carotid perfusion at 24 degrees centigrade is used for cerebral protection. Olden days, I mean, you know, it was total circulatory arrest with retrograde perfusion to the SVC. That is not done in many parts, so it has been abandoned. So I always use hypothermia, 24 degrees centigrade, and bilateral carotid perfusion with open arch anastomosis.
What do you do when there is a malperfusion, Bashi? In type A,
Yeah.
there is, let us say, the one of the kidneys arising from the false human.
Now, if kidney, most of the time it's a dynamic obstruction, we go ahead and correct the type A. See, other than visceral malperfusion, the most 95% of the time we just do the type A dissection first, and then if the kidney doesn't function, you can put a stent graft into the kidney. That is the only way to do that. If it is a static obstruction, dynamic, most of them will get corrected by this. And also another thing I noticed that in even type A and type B dissection, the kidney will open up. I had cases where after 3 weeks also, we have done the procedure with the renal failure. Once you do the correction, kidney will open up. So always in renal dysfunction, in aortic dissection, you should tackle the dissection first and without tackling the kidney. 3-4 dialyzed patients, I remember. I just did one. Couple of them had endografts, and then a few of them had a hybrid. They all recovered completely. So the correction of the primary tear is of utmost importance in renal malperfusion.
There is one good question in the chat box. When will you advise surgery for somebody with a bicuspid aortic valve?
Yeah, bicuspid aortic valve is a very interesting pathology. So, I get a lot of referrals from so many people when the diagnosis, even just now also I had an ophthalmologist from Ludhiana, and his son is having bicuspid aortic valve. So there are 2-3 indicators. One is bicuspid aortic valve when the aortic diameter is more than 5.5 centimeter. Anything above 5.5 centimeter with a normal bicuspid aortic valve is an indication for ascending aortic replacement. Okay. Then aortic valve stenosis. When there is significant aortic stenosis in bicuspid aortic valve, even if the aorta is enlarged 4.5, it is an indication for surgery. So what is to be done is the next question. If the aortic sinuses in bicuspid aortic valve, most of the time, the non-coronary sinus is the one usually dilated and ectatic. So you can just do the ascending aortic replacement with a tongue-shaped graft going to the aortic sinus and leave the other sinus alone and replace the aortic valve or repair the aortic valve. But if the aortic sinuses are ectatic in a bicuspid valve, you have to do a Bentholz operation. So when the aortic stenosis is severe, there is no question, we have to operate. Severe aortic stenosis is indication for valve replacement or repair. In those situations, even if above 4.5, if the aortic diameter is less than 4.5, usually not necessary to do anything to the aorta. If it is more than 4.5, you have to either replace the ascending aorta or do aortic replacement. And now, a lot of aortic bicuspid valves are being repaired. A lot of new techniques. In fact, we are having a aortic workshop in November, where we will have at least 3-4 cases of bicuspid valve repair being done for this, cutting the raphe. And they have at least about 15 to 20 years of follow-up doing well. Ultimately, they may require replacement of the valve.
Dr. Achal Dheer, who's a professor at the University of Western Ontario, Canada, has his hand up. Achal, you wanted to say something?
Yes, thank you very much. I actually joined your seminar quite late, but I'm quite interested in this particular topic. Only last week, I was involved with type A dissection, aortic root, ascending aorta, and arch with elephant trunk replacement. And yes, just a point that the operation for type A dissection, the mortality is simply related to the time. We need to intervene as early as possible, as soon as it is diagnosed. And sometimes, or most of the times, we start this operation in the middle of the night or late in the evening, which goes on for 12 to 14 hours. And we just have to focus on type A dissection first. Rest of the complications we can tackle later on. But again, thank you so much for this important topic and discussion.
There's another question by the same person who asked about the bicuspid. Sir, what is your technique for ruptured aortic aneurysm into pericardium with hypotension, since these patients are at risk for cardiac decomposition during anesthetic induction? I can't get the name of the person.
No, it is, so usually when these patients come in cardiogenic shock, we usually push the patient straight to the theater and put them on peripheral bypass to support, then only we even open the chest, femoral cannulation, femoral cannulation, go on bypass. And they will be having a lot of metabolic problem, hypotension, acidosis, and then open the chest and relieve the tamponade. But these are dire emergency. You need everything available. Perfusionist, all the things will be ready in the theater to tackle these type of cases. So in best situations, they can be salvaged. Across a lot of these patients. The US and all certain centers, they airlift the patient. Now we have one of the centers whom I know where I visited also. They have a specific the special center in Pennsylvania. Dr. Joe Bavaria's unit. They have a helicopter on standby. Aortic dissection anywhere they pick up, and any time of the day or night, immediately they will operate the patient. So as early as possible, because otherwise these patients will just die in matter of minutes and hours.
Dr. Hemant Vaikar has his hand up. Dr. Hemant?
Yeah, excellent presentation, sir. I just wanted to ask you, apart from antegrade cerebral perfusion and moderate hypothermia, do you use any pharmacological adjuvants for cerebral protection? Because sometimes total circulatory arrest may go beyond 60 minutes, which is recommended. So is there any pharmacological?
Earlier, pentothal we used to use earlier and gives methyl prednisolone 1 dose. Earlier on, when we used to do, I mean, in the early I started arch surgery about in 1990. Actually, those days it was used to be total circulatory arrest with profound hypothermia. That is, we cooled the patient about 15 degrees. So we used to give pentothal, big dose of pentothal and steroids also. And then we give retrograde perfusion through the SBC, because you cannot go more than 45 or sometimes 1 hour maximum. But now with the antegrade perfusion going through the carotids, we don't give anything actually. We do cerebral monitoring, and then nurse is very good. That is what we do. So, and most of the time, there are some centers they do only a single perfusion of the carotid, and they don't do both the carotid. Single perfusion also is being done in some centers. If the circle of Willis is good, that is enough, because too many cannulas into the carotid also is a problem. And another thing also is putting some centers that are still doing circulatory arrest, because see, when you get very old patients with a lot of atheromatous lesions in the carotid, passing this cannula itself can sometimes embolize and produce stroke. Fortunately, in India, we don't get such old patients, so I still keep using the antegrade thing. But a patient who has a very calcified artery, there's nothing wrong. It is still a good technique. There is a very famous surgeon, Dr. Hassan Safi from Texas Art Institute. He has a series of more than 1,500 cases on circulatory arrest. I listened to his talk a few years ago. He's a big proponent of total circulatory arrest with profound hypothermia. He says his results are same as antegrade perfusion. But by and large, almost 90% of the centers all over the world uses antegrade perfusion to the carotids.
Do you use fibrin glue routinely for these cases?
Not routinely. Dissections, I never used to do glue earlier on. Nowadays, I start for dissections, I use it. Yeah.
It's very fragile aorta, and it's very difficult for.
Especially preparation of the proximal stump, it is good. Actually.
Yeah, it's like a butter actually when you stitch it.
Cheese.
Cheese, yes. The cheese, not the butter. That's a correct word, yes.
Now, the point about the aortic diameter also very true, because our average infrarenal aortic diameter is only 1.6 to 1.8. Well, we are still following that Western advice of 5.5 as the magic number over which the aorta is going to rupture. We have seen number of patients with lesser diameter rupturing.
Yeah.
So we need to rewrite that.
Yeah, in fact, I'm just doing I can't tell anything now, a study on this actually, on the, some work is going on. Statistically, we have to get analyze some data on the aortic diameter in Indian patients. So maybe in another year, we will get some data. Because every time most of the things that is happening is everything we have to compare. Any meeting you go, you say all the data is not, you don't have anything to present on our own, unfortunately. So hopefully the next generation can do some more of work, and facilities are available for studies. Routine CT scan, so many things are being done. So I'm sure in the future, we will have to have our own, maybe vascular surgeons and all of us have to sit together and make some guidelines for our own patients, because nobody else is going to do that actually. Yeah. Yeah.
So, Dr. Shekhar, you wanted to add anything about the parts that Dr. Bashi left out about the aorta?
No, nothing. See, like we've also moved into in vascular surgery. We also moved into endovascular regarding aortic aneurysm surgery. Of course, still the dictum is if the patient is fit candidate, young person, should undergo open surgery instead of EVAR. Even though whatever is said, newer devices have come. The one great disadvantage of EVAR is that you need lifelong follow-up, because the aorta continues to grow and there are no sutures to hold that device. It can slip. When the aortic neck dilates, the device can slip, can migrate, endoleak will happen. So you'll need some more procedures. So in long-term follow-ups, EVARs are failing. You have to accept that. So you should advise an open surgery whenever a patient is fit. If the patient is unfit, then ideal that we can do EVAR and get away with it, because perioperative mortality and morbidity is very, very less, very less.
I fully agree with Shekhar. Because even recently also, there was a large study. It has come out about the EVAR. They are comparing infrarenal aneurysms, open surgery and EVAR. The second re-interventions, number of investigations done post-operatively, and long-term results are much superior in surgery compared to EVAR. Yeah. But probably one thing is, if you see, maybe the hardwares are, they are becoming better and better quality. So unless that comes, at least in our setup, I think a patient who is fit for surgery and somebody who can operate properly, nothing like a direct surgery. And the first aortic or total thoracic aortic arch replacement I did in 1993 is one of the longest survivors in the world itself. She's still alive, a nun's sister. I did total thoracic direct surgery. If I put endograft, I'm sure she would not have been allowed, or she would have had about multiple reoperations. Yeah.
Very true.
Shiv, you have your hand up. Like say something.
Yeah, so I have been involved with the endovascular work from the time we were using the primitive grafts, which used to take the whole day, till the present one where they have a branched EVAR, fenestrated EVAR, something. And you're very right, Sege, that the life of the graft is limited. I have now actually done quite a few cases where we actually had to open the aorta and take out the grafts and do a traditional surgeries, because these were done in younger patients. So younger patients, you're right, endovascular repairs are not the treatment. They don't have better outcomes, and life is less. So the open aneurysm do last longer, and they do better. The other thing with the endovascular work, these are all custom made grafts, especially if you're looking at the fenestrated or branch grafts. These are all custom made, so you can't actually use them. And not all anatomy are suitable. Even if you actually have a graft with you, not all anatomy are suitable for endovascular repair. So even if you get a case in emergency, you may not be able to use the endovascular, even if you graft, even if you had them. Thank you.
Radhakrishna, you were the one to suggest this topic. So what do you have to say?
No, actually, the topic you should have named it. Aorta is not a silent killer. It's a very loud killer. Because all aortic diseases produces severe pain. It's just people don't diagnose it.
But it comes silently. See, like one patient came when he was sleeping. He had a ruptured aorta, the angio I showed. Afternoon, he had a nap. He woke up, he could not move his limb. It can be either way you can put it.
I actually looked at it the other way. There is a lot of noise made about cardiac surgery and brain surgery, but aorta goes kind of below the radar. I thought that's what you meant by silent.
Yeah, correct. I think you are right.
Hey, another thing you have not covered, Bashi, is that intramural hematoma, penetrating aortic ulcer.
Yeah, I know. See,
that is also, it's becoming very common.
I know. See, I wanted to make, because in 45 minutes, I won't be able to cover any of these things. So many things I have not done actually.
Yeah. And the audience is mixed, sir. We're not like.
I was told it should be just a very superficial talk. Otherwise, I could have covered the whole thing, because as frozen elephant, I have so many videos and CT angiograms. I didn't want to, overload with so much of it.
Yes, Shiv has got his hand up again.
Yeah. Shiv, your hands up.
Sorry, that was actually by mistake.
Okay.
I'm not putting my hand down. It's not that. It's a hand down. It's not that I just want to speak. Sorry.
Yeah.
He is waving out to somebody.
Vidya, I should admit that this is a very special, marvelous medicine, because two of the finest surgeons I've seen are participating in this. And I should say that I'm lucky to be known, and I've known both of them. And that Shekhar is one of the finest surgeons I've ever seen. He was my teacher. He was in the same unit as me when I did my MS general surgery way back in '86. And then, he's not just a fantastic surgeon. He does with the least of assistance. Even if there's no assistant, he does vascular surgery. I never saw him getting irritated, angry, casually, very casually, as if it's nobody's business. He does vascular surgery. And then now to talk about Dr. Bashi, I think I'm a very small man, but I am very, very privileged to rub shoulders with him every day in the changing room and in my day lights up. A senior cardiac surgeon. I've been hearing about him from my very young days, and then here I am, operating on the same floor as him, and then he's so down to earth, so unassuming and so pleasant. I keep telling him, sir, I see you, I get inspired. Now, leave that alone. Aortic surgery is like hydrocele surgery for him. Because aorta is the most scary thing which I've been, associated with. Because we have thought that if you injure the aorta, it's gone. And no general surgeon can do anything about it. I mean, there's the end of the story. Unless it's a cardiac surgeon with the hand's breadth, the patient will not survive. I was talking about trocar injuries in a laparoscopy. But then, long surgery, Dr. Bashi will just be as fresh as he starts the day. A long, lengthy aortic surgery. He would have done one the previous day. I don't know where he gets the stamina, but the same smile and, actually, you inspire me a lot, sir. And the talk is so very simple and pleasant and easily understandable by everyone. It's so diagrammatic, and I really love the talk, sir. Thank you so much for participating in this session. And thanks, Shekhar, sir. Dr. Shekhar is senior by about a decade, Vidya.
Dr. Achal, you have your hand up. You want to say something?
Yeah, just again a small comment about the bleeding with this aortic arch surgery. Of course, aortic aneurysms, we probably do many of them without any blood transfusion. We use the technique of ANH, acute normovolemic hemodilution. They're all controlled and elective procedures, so that is fine. But when it comes to an emergency operation like type aortic dissection, and especially in the middle of the night, and on top of that, if patient is already on, say, any newer oral anticoagulant agent, which we do not have any the ideal antidote for example, apixaban or rivaroxaban, we still carry on with the operation, but we know that we end up in a massive transfusion. And so I have seen that aortic arch surgery basically drains our blood bank resources to a massive amount. And the case I was referring last week, which I did, was we had to resort to a half dose of recombinant factor 7. So my just, not a question, but just your opinion on this and your experience on use of recombinant factor 7 or PCC, that is prothrombin complex concentrates, apart from fresh frozen and other stuff, blood products.
One problem which we have is it's so expensive. Factor 7 is all these products that, it costs almost like 5 to 7 lakhs for that thing. So normally what we have been using is fresh blood. Most of the centers, they don't have the availability, all use blood components only. I usually have about 6 or 7 people ready to donate warm blood. We give straight away. That is what we give. Other than single unit platelets, SDP, single donor platelets we give. That is a common. Very rarely, I have not used factor 7 so far in my practice. Only maybe one case of thoracoabdominal case only I have used.
Now PCC is available. It's not very expensive.
Yeah.
So while as you were talking about both our speaker and moderator Radhakshana, I learned all my anesthesia for vascular surgery from Dr. Shekhar, because I'd never seen anything when I started, hadn't even seen a proper vascular surgery when I started working with him. So not only he just quietly does the surgery alone, he's there to teach anyone who's ready to learn as well. And so we didn't work we worked in different theaters, but I also had the pleasure of being a colleague of Dr. Bashi, and we had the dubious distinction of getting sued by the same patient, but then the case was dropped off by the litigant for some ridiculous reason. So what you say is very true. I mean, you can always see him looking very fresh and with that smile, and now even after, I don't know, 10 years, 15 years, he still looks the same, and he still has the same smile and looks just as fresh. So nice catching up with you again, Dr. Bashi. Does anyone have any questions? Otherwise, we're ready to close. Oh, there is Dr. Vasanthi. Yeah, so Dr. Vasanthi agrees with you, Dr. Bashi, that whole blood transfusion seems to do the trick when you don't have fancy things. But most of our blood banks nowadays, like you mentioned, we don't use whole blood at all. So except a busy cardiac unit like yours, obviously you will be having people on standby. So what do you do when it's an emergency surgery, sir?
No, emergency, we always use only blood products, like, platelets and whatever is available. There is no other choice. In that situation, We don't have a choice. Somehow we manage because I noticed that blood is not a very big problem in Chennai now because a lot of groups are there with WhatsApp group and people are young fellows are willing to come and donate even in the middle of the night. We never had a problem with getting blood actually. Yeah, because somehow we will manage.
So if nobody has any other questions or comments, we'll close. Thank you, Dr. Bashi, for immediately accepting and, even at a very short notice as well. Dr. Shekhar has always been supportive of marvelous medicine. Thank you, Dr. Shiv and Dr. Hemant and Achal who have joined despite different time schedules in their countries. Thank you everyone who joined in and for all the active discussion that happened today. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Thank
Thank
you.
you.
Thank you. Thank you.
Bye, Bashi.
Bye.
Bye bye.
Bye-bye.
Good night.